everyone for having me here. It's great to see a great turnout here and some familiar faces. So it's my pleasure to be here. Kenneth asked me to speak for tonight, and he said that the topic was going to be side effects and interactions with HIV medications. And so when, as a pharmacist looking at HIV medications and side effects and interactions, there's a very, very, very long list of them. There are a lot of things that I could have talked about here, but I'm going to keep it a little bit casual. And if anyone has any questions as I go along, please let me know. If you can't hear me, let me know. If I'm speaking too fast for the translator, let me know. Okay. Hopefully we can generate some discussion as well. So I think that would be nice to have some back and forth. So just start off with disclosures. I don't have any affiliations with any sort of drug companies to declare. My affiliation is really just with Moss Park Pharmacy. And a lot of you are familiar with us and our services here. Okay. So very briefly, this is the outline here of the presentation as I go through. I'm going to talk in general just about give a little bit of an introduction about how I approach this presentation. Talk just to make sure we're all on the same pages, some abbreviations and some products. And then looking at current therapy and in particular initial regimens, just because that ties in a little bit in terms of our goals of therapy, which is actually a little bit further down. And in particular, one of the bigger things that has come up recently is the differences between TDF and TAF, which we'll talk about. And then on the right side there, looking at concurrent drug therapy. So how do your HIV medications interact or affect different health conditions, different medications that you might be using? And there are a bunch of different topics to that. Some of them had been suggested by Kenneth, and some that stood out to me as important with respect to HIV medications in general and some of the newer medications that are out. Oh, and then also some current issues with respect to health and health promotion. So, the overarching theme of this presentation, or the way that I approach this, is that people are living longer now, and much longer with HIV than back years ago in the 80s and the 90s. So about now, the life expectancy of a person who is newly infected with HIV is about the same as a person who does not have HIV. So HIV therapy is greatly improving, and people with HIV are living longer lives and more meaningful lives. And so one of the things that are associated with aging is that as you age, there's an increasing chance of developing other health concerns that are outside of HIV. So, just looking at our big things like hypertension, so high blood pressure, or diabetes, and this is, I think, a bit of a newer area for people with HIV because people are now living longer. We're seeing now people who have HIV reaching older ages, and so how do these diseases tie into HIV medication, and how do we manage any sort of drug interactions or concerns? So the topics that I brought up, as I said, have to do with the fact that people with HIV are living longer, and looking at some of the diseases that the general population would have as they age. Okay, this is not all inclusive. I've selected some drug classes here just because of what we're looking at currently with respect to initial therapy or initial regimens. These are the most common ones that we have. There are some other drug classes outside of this. But I've selected these ones, and we'll talk about that a little bit later. So I'm sure you're all familiar with these, or most have some familiarity with these. So your NRTIs, the nucleoside or nucleotide reverse transcriptase inhibitors. You have your NNRTIs, your non-nucleoside reverse transcriptase inhibitors. INSTIs, integrate strand transfer inhibitors, and then PIs, protease inhibitors. So these make up the bulk of our initial therapy regimens that are in the current recommendations. Okay. Again, so these are some specific drugs. All of the drugs can be shortened into 3 letters. I've picked these ones. Again, this is by no means exhaustive, but these are the ones that are represented in the current initial therapy regimens. And so, a lot of you are probably familiar with some of these. There are some other agents that we still use commonly today. But they tend to be people who have been on therapy before. They've had to switch therapies, or they've been on therapy for a long time now, and they're stable on that, so they're on an older regimen. But these are the more common drugs that we'll see as initial therapy regimens. A few things to point out. So in the NRTIs, there used to be TDF, which was tenofovir disoproxil fumarate, and one of the newer NRTIs that has come out recently is TAF, tenofovir alafenamide, which has, we have a slide dedicated to this one, or section dedicated to this one, because this has been a large focus for a lot of changing of therapies recently, and a lot of I don't want to say health concerns, but looking at long-term HIV therapy, and this is one that has really brought into the spotlight the fact that people with HIV are living longer and are having to deal with health issues that affect people later in life. The INSTIs, so the newer agents, dolutegravir, elbopegravir. Again, these are the ones that we see more commonly with respect to initial regimens, because they have a great safety profile compared to some of the other agents, and we'll see later that they're very convenient for people to use. And in RTIs, so adherence is still used fairly frequently. Now we're seeing some rilpivirine as well in fixed dose combinations. But there are some issues with those ones that we'll address a little bit later. And then the protease inhibitors, still a lot of people are on these, and these are great agents for certain populations. Darunavir and atazanavir are the most common ones that you'll see nowadays. The boosting agents, these ones are particularly important. So there's 2 of them now. Ritonavir or Norvir, that's been around for a long time, but now there's a new one, cobicistat, which is included in combination products. And the boosting agents are really important for consideration when we're looking at drug interactions, because really the role of the boosting agent is to change the metabolism of some of the other drugs. So the beneficial effect we see from the boosting agent is that some of the other HIV medications, include, especially the protease inhibitors and some of the integrase strand transfer inhibitors, they work better when you use a boosting agent. The flip side to that is a lot of other medications will be metabolized a little bit differently when taken in conjunction with the boosting agent. And so those are important drugs when we're talking about drug interactions. Yes?
I have a question. Is there any possible way you can explain it, like we use the term like Genvoya, to the K influence, what class it falls into, like each
So sure, I can do that, and I have a slide here. I have a slide here that talks about specific products and with the brand names, which I think is where people will be more familiar with.
Oh yeah.
Yes. Yeah. Okay. So so the you can in this slide here. So I talk about specific products that we use that use these drugs and drug combinations. Truvada used to be one of the more popular ones. It's now, you might also see these now in generics. So some of these drugs have, their patent has expired, so the name might have changed a little bit. But Truvada used to be the original brand name product. And this one has that older drug in it, the TDF in it. The newer version of Truvada is Descovy. So some people have been switched from Truvada to Descovy because the Descovy has the TAF in there, and there are potentially some health benefits of having the TAF over TDF.
Excuse me, Truvada and Descovy, which one more offensive?
So I'll talk about that a little bit better. It's not a straightforward answer. Okay, they're both very good. When we talk about first-line therapies, they're both considered first-line therapy. And when we talk, the differences between Truvada and Descovy, it really depends on what else is going on with you. So do you have any other risks for health conditions, things like that, in terms of deciding which one we would prefer you to be on.
Yeah, of course, before they switching, they check on everything about your medical conditions, but I want to know the price.
The price, okay, so price, Descovy, just by virtue of being newer, will be more expensive. Truvada, because there are generics available, because the patent has expired for that drug, there are generics available that will be significantly cheaper. Both of these products, if you have coverage through the Ontario drug programs, both of them will be covered under the drug plan. If you're paying out of pocket or looking at other support programs, I think we still see some for Truvada, but most of the support programs are now for Descovy because it's a newer drug. So the manufacturer tends to promote the newer drugs. Cavexa, we still see Cavexa used fairly often, especially in people who are not good candidates for either Truvada or Descovy. But that, again, that's an older drug, and you'll see some generics available for that one. The integrase strand transfer inhibitors. So these include drugs. Tivicay is just the INSTI by itself. Triumec is the combination product with the Tivicay in it. Stribild had a very short. We still see it sometimes, but Stribild came out, and then shortly after Genvoya, they both contain the same ingredients, except for the Stribild has the TDF, and then Genvoya has the newer TAF. And then Icendris is their last INSTI that we see in. That one, at the moment, not available in a combination pill or a single pill, because it has to be dosed twice a day, rather than the other ones that are dosed once a day. Then some other combinations that we have, again, looking just at some of the more common ones that are in line with the initial drug recommendations. So Sustiva.
Sorry. I have a question there.
Yes.
Is Sustiva still considered to be the queen of the HIV medications, or there is another one?
So Sustiva is not very commonly used anymore. It used to be, I would say, 3, 4, 5 years ago perhaps, that used to be the number 1 recommendation for initial drug therapy, because it was available as a tripla, as a single drug combination, had great evidence. It still does, it still works very well. The reason that we're seeing a switch over to the other drugs, Triumec, Stribild, Genvoya, is because those drugs, the newer drugs, are associated with less side effects than the other drugs. So it's still a very good drug, and especially people who have been on it already and they've tolerated it well. It's still a very good drug, but for people who have never been on therapy before, they usually recommend starting with one of the newer drugs.
You believe that?
So Genvoya doesn't have Sustiva in it at all?
No, it does not. Genvoya, there's actually, so it's the architecture here that's in Stribild and Genvoya. It's actually not, it doesn't have its own. I think it does have a single drug product. I don't know what it is. No one uses it, only in the combinations. So in the NNRTIs, we are also seeing some Complera, which was a newer one that came out a few years ago, and then now the Odefsey, which has, again, the newer TAF versus the TDF that's in the Complera. Okay, and then last, the protease inhibitors, we're still seeing some of these, so the Prezissa, or the, I can never say this, Prescovix, which has the boosting agent in it. There is also now a combination pill available that has the protease inhibitor plus the NRTIs in it. Simtuza, it's unfortunately not covered yet through Ontario drug programs. I don't know about programs through the manufacturer. I haven't seen any yet, but it is available in a combination pill as well. And then the last one, Reataz, is also an older drug. Generics are available for that one as well, but we still see that used fairly frequently. And then the boosting agent, the only boosting agent that's available by itself is Norvir. And again, this one is also available as generic, so you'll see some generics in there as well. Okay. Yes?
Question before you go on.
Absolutely, yes.
You've been talking about boosters
Yes.
and how they enhance the medication.
Mm-hmm.
My question is boosters, how does it affect the half-life of the medication for those of us who miss?
For those of you who missed.
Yeah, or don't, not compliant. Because the boosters are there and they support the medication.
Mm-hmm.
I'm sure it affects the half-life of the medication.
So, as I mentioned, the boosters are there. What they do is they make the other drugs stay around in the body a little bit longer. So you can see some of these combinations have boosting agents in them: Stribil, Genvoya, Prescovix, the Simtuza. So the boosting agent, what it does is it makes the combination of one of the drugs, in this case the Albuterravir or the Darunavir, higher, so that it works better.
So in theory, it doesn't drop.
In theory, it lasts in the body longer. However, still highly recommended not to miss doses, just because in theory it will last a little bit longer, but we don't know how that impacts missed doses, and if that is high enough to make up for a missed dose.
So yes, on that note, what kind of math do we do in terms of U equals U?
U equals U. U equals U, I think, and you're I know you've had talks on U equals U through ACAS. Lots of them. You guys are probably actually better versed at this than I am. That is, I would say that is more of an issue for, from a legal perspective or from an ethics perspective. There's no math involved. It's not like I missed this dose and then I'm still not detectable or will still be untransmittable after so many hours. It doesn't necessarily work that way. And the way that these medications work, it's not going to be an exact science like that where I could say, okay, I missed this dose and I'm still good for another 12, 24, 48 hours. That's not how.
Yeah.
So.
I think that the way I was asking the question is that if you correct me, Derek, on your own words, what I was understanding is you said missed dosages, so that means we have missed them more than once or all.
It doesn't.
I have.
So.
And
I think the short answer you're going to get is that I don't think anyone's looked at that at the moment to see if.
What to speak without fears.
And I think when we looked at some of the other some of the earlier studies when you're looking at RNA suppression with boosting agents, they were, those boosting agents have been around for a while, and the recommendation is still keep that adherence as high as possible, and any sort of missed doses can cause a blip in your RNA level.
Can I just say something? So from my understanding of U equals U, so even if you're adherent, your viral load differs every day. So there are viral clips. So if you actually consistently measure your viral load every day, they're not going to be the same. But it's overall, if you have a suppressed viral load, which is 200 copies per milliliter, or less than 40, which is undetectable viral load, then sexually you won't be able to transmit HIV to your sexual partners. And that is over a long range. That is why it's important when you talk about U equals U, you need to be on effective treatment, meaning that like the virus is not mutating, is your treatment is working and not having a resistance that your body is not having a suppressed viral load. You need to go get your blood test at a regular interval. So right now, a lot of people get tested every 3 months or 6 months, right? And I think that's why when they say someone start treatment for U equals U to apply, you need to have reached undetectable viral load to know that the treatment is working, and then you need to wait 6 months first to have that suppressed or undetectable viral load, and then after that, if you're still having an undetectable viral load, then U equals U will apply to you.
But here in Canada, you still need to disclose and wear a rubber. In Ontario, they've stopped the criminal prosecution, but you can always be charged.
Can you continue? Thank you.
Clarification. I want to also take this moment to bring up a point. We were talking about us, PHAs, living longer.
Yes.
Like myself, right? There's no research on this, but you work down in a pharmacy. A personal reflection. Quality of life. Are we happier? Are we...
So I think it varies.
Because I know, but the reason I'm saying this because in most part, invest like coming here to ACAS and keep, and does things.
So I think with any population, this will vary. Everyone is a little bit happier, or some people are happier than others. And what I must say is that it's the people who have a sense of community. Right? that and they have those social support systems that they have better well-being or overall mental well-being in terms of there's a sense of belonging and a sense of purpose. So it's hard to say. It does fluctuate, but in general, I find that the people who have good social support structures, those are the people who tend to have a better quality of life.
And be more compliant with your medication. I think I totally agree with that.
Okay, so we talked about select products, and that's really just to get again talking about preferred initial regimens, and for some of you, or this may or probably doesn't apply anymore, but now when we're looking at the new recommendations, if someone is newly diagnosed with HIV, regimens containing the integrase strand transfer inhibitor plus 2 nucleoside reverse transcriptase inhibitors, NRTIs, this is now preferred for treatment-naive patients, and there are several reasons for this. And one of them is that the INSTIs, they're better tolerated than the other HIV medications, so compared to the protease inhibitors or the non-nucleoside reverse transcriptase inhibitors. And these formulations are available these regimens are available in 1 pill per day formulations, which makes it very simple for people, and I think that's what a lot of people prefer, and it helps a lot with adherence to have a simple regimen. There are some side effects that are associated with the integrase strand transfer inhibitors. Most commonly, we see things like headache, insomnia, maybe some nausea and diarrhea, but the incidence is very low, so the proportion of people who have those side effects is still very low. Those drugs are very well tolerated. As I said, the other medications or the other combination pills are still used in other certain situations, especially for people who are treatment experienced. The reason I bring this up, really now a lot of the newer agents, as we see, they are available in 1 pill per day formulations, which makes it very simple for people. and that ties into adherence, which ties into suppressing that viral load. And so the more that the simpler we can make that regimen, the better. And we'll talk about how that applies to people who are treatment experienced. Okay, so I mentioned this a few times now. TDF versus TAF. So you see a lot of combination pills that are coming out that kind of look like older versions or older medications, but they're slightly different now. And usually it's this product that has changed. So TDF was the old one, as I said. I guess the most recognizable drug would probably be the Truvada. And then the new one, Descovy, has the TAF. It's the same active chemical, but the form of it makes the drug accumulate in the body differently. So that has implications in the side effects of each of the drugs. And what we're seeing, or the reason that TAF is becoming more popular, is because it's less likely to cause some of these side effects that we're seeing with TDF, such as decline in kidney function or decrease in bone mineral density. And both of these, for people who are getting older, these become more prominent concerns as you age. Kidney function, by virtue of getting older, kidney function will decline. Same with bone mineral density. So as the HIV population ages, these become much more important things to consider when we're starting new therapy.
That is the same
Reataz, so Reataz is a protease inhibitor, so it doesn't cause the same effects here. It depends on what other drugs you're on with the Reataz.
Also, it doesn't necessarily has to affect your
Sorry, say that again?
it doesn't necessarily has to be a concern for your kidneys taking Reataz.
Reataz, okay, so I think two different things here. So if you have declining kidney function, then there might be concern with Reataz and like, can you stay on that therapy? But if you're on, let's say that your kidneys are fine, the concern here is that if you're on a TDF regimen long term, then you might go into declining kidney function sooner. And that's why we have this preference towards TAF for most people. That being said, so TDF is associated with lower lipid levels than TAF. So when we're talking about things like cholesterol, and that ties into heart health, potentially TDF is preferred over TAF. And so, when you're talking about which one is better, it's really hard for us to say. It depends on your medical history and which of these factors you are more at risk with. So if you have, let's say, a family history of low bone mineral density, then we might prefer you to be on TAF. Versus if you have, let's say, family history of high cholesterol, then that might be a bigger concern, and we would consider TDF. Yes?
Quick question, since you were mentioning ritonavir, right? Not ritonavir, Truvada.
Yep.
Truvada is what they use for PrEP.
Okay. Yep.
And it has side effects. It's bad
For
for your
sure.
kidneys.
For sure.
This is just HIV positive comment.
Yeah.
Why the hell would you want to take it if you're not HIV positive, HIV medication? How does it affect non-HIV positive people, like the Truvada, us?
So again, newer area. PrEP is fairly new when we talk about HIV therapy or HIV treatment. Likely those side effects that we see with TAF and TDF. So what TDF, that decline in renal function or that bone mineral density, likely people who are on PrEP, if they're on PrEP long term, might see those same side effects as time progresses. I think it's too early for us to really tell, and it might be that the people who are on PrEP versus people who are on HIV therapy, there are differences there. But we would expect to see probably that TDF would have the same effect in those people. So people who are on PrEP, this might also be a concern, and potentially we might see a shift of therapy for PrEP from Truvada to Descovy because of that, because of those side effects from TDF.
Yes, with the PrEP, they only take that when they're having sex, or they have to take it every day?
They take it, so with PrEP, there's there's a regimen that goes with it. So it's an everyday therapy, and you're supposed to make regular appointments with your physician to be authorized for PrEP, because if by chance PrEP fails and you become HIV positive, then Truvada on its own is not sufficient therapy, and that can put you at risk of resistant strains. So resistant strains to big therapy. So with PrEP, there's a very strict regimen. You're supposed to be on it daily. Yeah, so we call it while you have exposure to risk. So while you're being sexually active, then you would stay on that daily, and then making sure that you're getting your blood work done regularly.
Some people that ask me that they always tell me that they only take it when they have sex and not taking it with us.
So not fantastic, right?
No.
Definitely not recommended. You don't.
So if they you can try.
I think there are clinical trials that are being done right now to see if it's called on-demand PrEP, right? I think originally they were asking people to take it regularly because people tend not to remember to take pills. So, but then I think there are studies that are exploring whether, you know, if you take it before and then maybe like a few days after or whatever, whether that's just effective. The results haven't been released yet. So I guess as more evidence comes up, then we'll update you.
Exactly. Yeah, and especially if you're looking at on-demand, it's how soon or how quickly do you need to take it, and then do you if you're is there really enough time? How much time do you have in advance, or can you take it right before having sex, or does it need to be the day before? And then is there really enough time if you haven't been taking it at that point? So very highly recommended for PrEP to take it every single day. Yeah. Just in case.
It is a great engaging conversation, but I would prefer if everybody can hold their questions, whatever they come to mind, asking the questions at the end, so
Sure.
let Dr. Chong finish the presentation.
Sure.
So we will able to get it faster, and then if you have any questions, just leave it at the end. Thank you very much.
Fair enough.
Okay, so, and then just as a reminder, so goals of therapy, for people who are on HIV therapy, we want to suppress plasma HIV RNA, restore and maintain immune function, so CD4 count, maximize quality of life, and prevent HIV transmission. And really, meeting these goals of therapy is dependent on people being adherent to their therapy. And adherence can come in many forms, so remembering to take your medication, or some people, they can't take it for whatever reason, or really the focus of this is unintentional inadherence. So is there something else that you're taking that is interacting with your HIV medication that is making it not work, and essentially you're now non-adherent to your HIV medication? So that's an important consideration when we're looking at the goals of therapy, and how do we minimize that potential for non-adherence, especially unintentional non-adherence. Okay, so the next section we're going to talk about concurrent drug therapies and different disease states. As I mentioned, a lot of these were suggested from Kenneth, and then some of them are things that have come up currently or have gained a lot of media attention lately. But as I had said before, there are lots of HIV medications, there are lots of non-HIV medications. So this is by far not going to be any sort of exhaustive list of potential interactions or side effects that you can have from your therapies. So these are just things to think about and consider as we go along, and as you age with HIV therapy, HIV therapy. So first one I want to talk about is over-the-counter medications, and this is a particularly important topic because as opposed to prescription medications, Over-the-counter medications, there's some, you have the ability to select these yourself, and potentially you can purchase and use an over-the-counter medication without having a discussion or interaction with a healthcare professional. So I think it's really important for people with HIV and non-HIV therapies to think about over-the-counter medications and think about what it is that they're taking outside of their other therapies to make sure that it's safe for them and it's not interfering with their other medications. So in general, so looking just at HIV therapy, in the absence of other medical conditions, most of the over-the-counter drugs to treat certain conditions, so the ones listed on the slide, can be taken with HIV medications without worry. So things like mild pain, if you're looking at acetaminophen or Advil, they don't interact with HIV medications. Products for cough and cold, most of them don't interact with HIV medications, although there's one exception that I'll bring up later. Things for diarrhea, constipation, those medications again don't interact, or things to treat seasonal allergies. These are most of the big categories of over-the-counter pills that you would take orally to treat minor conditions in a pharmacy. There are some notable things though. So medications used to treat heartburn, so these should always be used with caution. Okay, antacids, things like Tums, Maalox, these may reduce the absorption of some of HIV medications, especially the integrase strand inhibitor, transfer inhibitors. And then antacids and other acid suppressants, things like Zantac, Olex or omeprazole, they may reduce absorption of certain drugs like atazanavir or rilpivirine. So you know, if you do happen to have heartburn and you're looking at over-the-counter medications, this is important for you. This is an area where it's important for you to have a discussion with either the pharmacist or your physician to make sure that the treatments that you're looking at don't interfere with your HIV therapies. Other over-the-counter medications that might be of concern, things like codeine, so Tylenol ones or codeine cough syrups. Some HIV medications might interfere with the metabolism of codeine. Things like multivitamins, they contain similar ingredients to your antacids that might prevent the absorption of your HIV medications. Any laxatives containing magnesium, again, might interfere with absorption. Iron supplements, and some herbal products. The one that we usually talk about is St. John's wort, but other ones such as I think ginseng as well have the potential to interact with medications, and so so herbal products. I think this is an often overlooked area. People think that herbal products, because they're natural, they are safe to take in all situations, which is not always true. So a lot of herbal products do interact with medications, and the last thing we want is for it to affect your HIV therapy.
Yeah, how about milk?
Milk?
Yeah.
So milk has calcium in it. For certain medications, it's preferred not to take milk with your HIV medications. So best to avoid if possible. It doesn't necessarily need to be avoid milk altogether. It's just you want to space it apart from your medications, and it's usually about 2 to 4 hours. So if you're someone who drinks a lot of milk, I'm lactose intolerant. But if you're someone who drinks a lot of milk, that's another consideration as well. It doesn't have the same amount of calcium as supplements, though. Okay, cardiovascular disease. So this is, again, a big area for people who are aging, lots of older people. We are very concerned about cardiovascular health. And there are some HIV medications that might exacerbate cardiovascular disease. Oh, before I continue, so for some of these diseases, there are lots of things that fall under cardiovascular disease. So things like high blood pressure. I don't really focus on some of those because if there are drug interactions, often what we do is we'll adjust your medications to based off of your readings. So if we're looking at blood pressure and your blood pressure is not a target, then we'll change your blood pressure medications. There are some outcomes with respect to cardiovascular disease that we want to prevent altogether. By the time we know that it's happened, it's too late. So things like heart attack or stroke, these are the big ones that we want to prevent them from happening before. Like there's no warning sign really, so we don't want them to happen. There are some HIV medications that might increase risk of things like heart attack and stroke. So abacavir, which is in Kevexet, and Kevexet, Triumec, and some of the protease inhibitors, including darunavir, they may increase risk of heart attack or stroke. And this is, it's not very well quantified, so we're not quite sure what that risk is, but potentially over the long term, these medications might increase risk of heart attack and stroke. And again, as we're looking at an HIV population that's aging or getting older, then this becomes more of a prominent concern. There are some other drugs, mostly the non-nucleoside reverse transcriptase inhibitors, so rilpivirine, efavirenz, also atazanavir. They might increase the risk of irregular heart rhythms, and this is again something that we would want to prevent. Some early signs of this, but sometimes it can just be full-blown irregular heart rhythms, so we want to prevent things like that. And again, these are considerations that we have depending on medical history and other medications that you might be on that do the same thing. Looking at, again, lipid levels, so abacavir and TAF, so Descovy, might increase lipid levels, and this might have an effect later in life when you're looking at your blood vessels and the plaques that form in them because of high cholesterol. When you're looking at medications that are used to treat cardiovascular disease, there are many potential interactions between HIV medications and cardiac medications, but most commonly, the most common culprits include things like boosted regimens, so Norvir or Covisistat, drugs that are used for specifically for irregular heart rhythms, and then anyone who's on blood thinners or cholesterol medications or statins. This is where we might have an interaction with HIV medications. And this is something that your healthcare team would look at it. And again, weigh the pros and cons of your therapy. Okay, mental health. So again, some HIV medications might exacerbate mental health conditions. The NNRTIs, so efavirenz, rilpivirine, and then potentially some of the integrase strand transfer inhibitors. They might, if you have existing mental health conditions, and usually the one that they look at is depression, might make the condition worse. For NNRTIs, this is a little bit more studied than the integrase strand transfer inhibitors. But again, this is looking at the pros and cons, so some people might still be good candidates for these drugs even though they have existing mental health conditions. As I mentioned before, there are some interactions, but most mental health conditions, the doses of your medications are adjusted based on how well they're working. So interactions are not necessarily a huge concern. The only thing we might consider, or one of the bigger things we might consider, many mental health medications can contribute to an irregular heart rhythm, which is a concern if you're on one of those drugs we mentioned before, so rilpivirine, efavirenz, or atazanavir. Okay, erectile dysfunction. So, most common drugs to treat erectile dysfunctions, they're in this class called PDE5s. Examples, most common examples, Viagra, Cialis, Levitra. So these medications, they are prescription only, but are often shared or gotten by other means. there are some potential interactions that might be of concern. So NNRTIs, again, efavirenz, rilpivirine, they might decrease the effect of these medications. But the more important interactions, so protease inhibitors and boosted regimens, so again, Norvir or gobisistat, they can actually increase the effect of these drugs, of Viagra, Cialis, Levitra, to the point where it's actually recommended to start at a lower dose than you normally would, so about 25% of the usual dose. And so this is important, especially if you're using these drugs without a prescription. There's the high potential for overdose if you're on a protease inhibitor or a boosted regimen. And overdoses might result in hypotension, so low blood pressure, where you might get dizziness or fainting, and then also priapism, so sustained and painful erections.
That Norvir would be, Norvir is the one that you were mentioning, right?
Norvir, yeah. So if you're on a regimen that has Norvir in there, then can greatly increase the effect of these medications. Okay, hormone therapy. So a lot of drugs, so the protease inhibitors, efavirenz, rilpivirine, elbapixvir, they have what we call variable effects on hormone therapies. So for all the different classes of hormone therapies, estrogens, progestins, androgens, anti-androgens, the levels might go up and down depending on what therapies you're on and what combination of therapies. So it's hard for us to really predict how hormone therapy might be affected by HIV therapy. So I've broken this down into 3 different classes. So I'm going to actually do the lower ones first. So menopausal hormone replacement therapy, so older women who are going through menopause. The doses of hormones are usually adjusted based off of their effect. So even if the levels are changing based off of antiretroviral therapy, we would just adjust the dose of the hormones. Same with gender-affirming hormone therapy. The doses are adjusted based off of the expected effects and the blood work. The big concern with hormone therapy is actually with contraception. Especially boosted regimens and hormonal contraceptives, there is potentially an interaction, so these should be reviewed carefully, and because you might have contraceptive failure or potentially low blood potassium. But really, if you're on hormones for contraception, we want to make sure that they're working well. Okay, hepatitis C. So, treatment for hepatitis C has improved greatly over the past few years. And we see a lot of people who are co-infected with HIV and HCV. So this is a very prominent issue recently, and looking especially at the concurrent therapy of HIV and hepatitis C. So the biggest thing I think to note about hepatitis C therapy is that it is very, 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 very expensive. And so the vast majority of people wouldn't pay for this out of pocket. They would get some sort of coverage through a program. And eligibility for coverage is based off of the type of HCV that you have, the severity of the disease. So some people might have HCV co-infection, but they're not eligible for treatment yet because of how severe the disease is. One thing to note, so being on antiretroviral therapy might slow the progression of liver disease caused by HCV. So if the disease isn't very severe yet, being on antiretroviral therapy might actually slow that progression of disease. There are lots of interactions between HIV medications and HCV medications, and there are some good combinations that we can have, or preferred combinations that we would use if we are treating for HCV in a person who is HIV positive. Because of the cost of HCV therapy, and because we don't want to have to retreat people with HCV, usually we'll change the HIV regimen rather than the hepatitis C regimen. So if you are co-infected and then become a good candidate for HCV medications, then what we would do is review your HIV therapy, have you stabilize on something else first, and then start you on HCV therapy. Okay, recreational drug use. So there are some potential interactions between recreational drugs and HIV medications. In most cases, the interactions involve boosted regimens. So again, Norvir, cobicistat, they tend to interact the most with other medications, including recreational drugs, which is always a concern because of the high potential for overdose. In particular, so there aren't any significant interactions with alcohol or amyl nitrates, which are poppers. I think the important thing to note about these medications are all recreational drugs is that everything in moderation, right? So they, on their own, these recreational drugs still are associated with their own side effects that need to be taken into consideration. So, so everything in moderation, but with respect to alcohol, poppers, and HIV medications, there aren't any severe interactions that need to be taken into consideration. Cannabis, so the only drug that really seems to have an impact or seems to interact with cannabis is atazanavir, which is Recreational. Cannabis may lower the concentration of atazanavir in your blood, but at the moment it doesn't actually seem to decrease the effect of that drug. So the level might be lower, but the drug is still working. Other HIV medications, cannabis doesn't seem to interact with them. The recreational drugs that are of bigger concern are the opiates, things like heroin, oxycodone, because of, especially with boosted regimens, because there's the potential that you can greatly increase the potency of those drugs, and there's a high risk of fatality or severe morbidity. Really cautious with those medications. And as I said, everything in moderation. And then the other thing that is important to know is a lot of drugs that, recreational drugs, especially street drugs that you can find, tend to be, or we're seeing now more and more often, they're being laced with things that you don't anticipate to be in there, and then all of a sudden people are overdosing. So, bad altogether, but with opioids, they can interact a lot with HIV medications, so something to keep in mind. Recreational drug users, so while there might be interactions between the drugs, HIV medications and recreational drugs, what we actually see is that recreational drug users, they're more likely to have treatment failure because of disruptions to daily life. So missed doses, inability to access the healthcare system, poor social support systems, rather than the actual interactions between HIV medications. And so people who use recreational drug use, they can really benefit from that social support system. Okay, opioid replacement therapy. We're seeing a lot of this now, especially with a lot of the overdoses that are happening in the community. Methadone and buprenorphine or Suboxone, these are the medications that we see for opioid replacement therapy. And like I had mentioned previously, these medications are dosed to effect. So there might be some interactions with HIV medications, but they're usually insignificant. We'll just adjust the dose of the replacement therapy. A couple of things that should be mentioned though. So anyone on methadone, methadone can contribute to an irregular heart rhythm. So those people who are on those drugs I mentioned before, rilpivirine, efavirenz, atazanavir, you might have a higher risk of having or developing an irregular heart rhythm if you're on that combination. And then anyone, combination of atazanavir and Suboxone should be avoided because there have been cases of accidental overdose with buprenorphine. So another area where we would be a little bit more cautious with respect to drug control. Okay, and then aging and cognitive decline. So as people age, and this happens with a good proportion of the population, in the general population, we see cognitive decline. So things like forgetfulness, poor cognitive function, and in other disease states, our concern is always missed doses, which is particularly important with HIV medications. So we talked earlier, we want adherence to medication to be really high with HIV therapy, and cognitive decline can contribute to missed doses and potential treatment failure. So, so the impact of missed doses on HIV therapy is potentially much greater than with other chronic diseases, and so it's important, I think, especially for people who are getting a little bit older, or who have people close to them who are getting older, is to keep an eye out for early signs of cognitive dysfunction. And some of the things that we look for are easy confusion, poor motor control, so inability. Some people are having difficulty with fine motor control, especially things that involve the hands, and being able to hold or grip things with accuracy. Loss of long-term or short-term memory, and impaired judgment. So, cognitive function, really important if there are signs of cognitive function to address them as early as possible. So if anyone has concerns about cognitive dysfunction, either in themselves or in someone close to them, important to speak to the physician for a more thorough investigation of whether or not there is actually decline there. And then potentially the pharmacist for coping strategies, especially to prevent misdosing of HIV medications. Okay, so switching gears a little bit, talking about switching regimens. So for people who are already on HIV therapy, on antiretroviral therapy, there are several reasons where we might consider switching therapy, and those reasons include treatment failure, intolerable side effects, drug interactions, or simplifying a regimen. And especially now with the availability of a lot of different single pill per day regimens, the regimen simplification, we're seeing a little bit more commonly recently, or in recent days. Because there are so many newer drugs available and new combination products available, it may be possible to switch to a simple regimen even for people who are treatment experienced and for people who have had past treatment failures, which may not have been a possibility a few years ago. Okay, so just some general comments, I guess, to tie things together. We talked about some specific disease states, some specific interactions, and what is it that you do with that information, and how do you handle that as a patient or as a person with HIV? And when it comes to prescription medications, your healthcare team is will usually help you make those decisions and come up with a plan that is tailored to you based off of what we know about you. So things like your over-the-counter, things that we know about you. So what other medical conditions you have, what other medications you're on. But we can only take things into consideration if we know about them. So especially important to make sure that your healthcare team knows about things like over-the-counter medications that you're taking, including herbal products. This tends to be overlooked very often. Prescription medications from other providers, any sort of recreational drugs, especially if you have the suspicion that it interacts with your HIV medications. So it's important for us to know about these so that we can help you navigate through this and make sure that your HIV therapy is not affected. Very much you are encouraged to ask questions about your care, and I know that I find that this group is very good about asking questions. But especially if you have any suspicions of health issues that you've identified on your own, or something that we've talked about in the previous slides that you want addressed, highly encouraged to reach out to your healthcare team, either to your pharmacist or to your physician, to make sure that your HIV therapy isn't being impacted. another thing to keep in mind is that HIV and aging is still a very new area. So you know, we don't have a lot of experience with, especially advanced elderly people with HIV. So still a new area, and we're learning every day. And so it can be difficult if you have questions about health conditions aside from HIV to find information that's specific to you. And I think in the absence of specific information for these diseases in people living with HIV, the best thing that you can do is follow general guidelines that are available for disease prevention. So, so general recommendations for things like vaccinations, routine testing, diet and exercise. You know, these are things that you should be considering and following the recommendations for the general population to make sure that you're living a long and meaningful and healthy life. And then just a reminder there, your body is a temple, right? So take good care of it, right? We're really seeing, can't emphasize this enough, people with HIV living much longer than we might have expected in the past. And so, so making sure that you're taking care of your body so that it will serve you well as you're aging and getting older. Okay, so that, in a nutshell, that kind of I kind of had a whirlwind through there. I know you have a lot of questions, so I'll open this up. Yeah.
Doc, because through the presentation, you have been saying that we are all getting older,
Yeah.
no one getting younger. Do you have the magic pill go backward? Because it's all concerned here.
So I think this is something that everyone has to deal with, the ever advancing age, right? Nothing yet, not that I've heard of, but when we do have something, we'll let you know.
Just take care of yourself, that's all. Right?
Right, and then you'll have to take even better care of yourself. Right? Chris, yeah.
Yeah, I guess ask, is that one specific HIV drug that have the least side effect?
Least side effects. So,
And then,
so when we talk about, this is why I brought up a preferred initial regimens. The reason that these are preferred, a lot of, when we look at the studies, a lot of them, they work in terms of suppressing viral load. They tend to work equally well, but the preferred regimens right now are the integrase strand transfer inhibitors because they cause the least side effects. So when we're talking about a best regimen, and this is for people who, as I said, for people who haven't started treatment already, this tends to be the best balance between working well and the least side effects. It's not appropriate for all people. So some people who have been on this regimen before, they might have developed resistance already, in which case they might not be a good candidate for being on one of these. But at the moment, this is what we would prefer for people because it has the best balance between effect and side effects. Yes?
How much is generic
Sorry, generic.
generic
Atripla.
Yeah.
Off the top of my head, I don't know. I think it's around, I think $300-400 per month.
Oh, okay.
So because it's now generic, prices come down considerably. It's still an expensive drug for people, especially if they're paying out of pocket, but has become much more affordable because the patent is expired, because they're generic.
I saw the internet, they sell it, they made it in India,
Mhm.
they sell it there.
Right, so in India, everything is cheaper in India. A lot of those drugs, they're not allowed to sell in Canada. And it has to do with different quality standards, I think. Not necessarily that there's poor quality in India, it's just that the regulations are different. But everything is cheaper in India. And we're talking about like many orders cheaper. So it might come down to, I think, maybe like tens of dollars per month versus hundreds of dollars.
One more question.
Yeah.
You want to ask, is any HIV drug really good for elderly people, specifically?
Specific for elderly people. So this is a good question, and I think something that needs to be explored more often. It's a very valid question. Because this wasn't something that was necessarily considered when we were looking at HIV therapies initially. Right? So definitely, as I said, some of these things have become more prominent, or we've started to focus on them a little bit more. So things like TDF, they tend to impact the body in ways that are more common, or more common concerns in elderly people. So declining kidney function, bone mineral density. Hard to say, right? So there are some, there is no ideal regimen. So when we talk about, so right, can I point? The NRTI, so most people will be on an NRTI and a combination of them. And the preferred ones right now, and this is based off of how well they work, preferred ones are either TDF, TAF, or ABC. And when we talk about HIV medications and aging, and trying to prevent side effects that affect elderly people, they all have something in them that might not be preferable. So TDF might cause declining renal function or low bone mineral density. TAF might increase lipid levels, so cholesterol. And abacavir might increase risk of heart attack or stroke in small amounts. So there's really no ideal. I think it really depends on your medical history and what your other risk factors are. Yes?
As we're talking about, so many points to bring out. My brain is going, because I have so many points written down. I got really excited. Let's start off with Gardasil 9. What's up with Gardasil 9?
Gardasil 9.
Because Gardasil 9, I'm too old for Gardasil 9. I love to give me Gardasil 4.
Okay.
But I mean, I was made aware of the fact that with men that have poor skin, as you get older, you are prone to cancer, for example. And this is a type of cancer called Bowen's disease, which is caused by HPV virus, which is preventable by the Gardasil 9 vaccine. But yet you will not give it to men because they are old. Do you have anything? My doctor said something like, when you finish your Gardasil 4, you'll start having your Gardasil 9. Any insight on that?
It's been a while since I looked at this. Gardasil and Gardasil 9. So they are vaccines for HPV and a certain number of strains of HPV. There are lots of different strains of HPV, so these ones are effective against certain strains. And they're effective against those certain strains if you have not been exposed to them. So when you say that you're not eligible, this is usually from a